Yeah, hello everyone, good evening. I hope I'm audible and visible. Give me a thumbs up. Yeah. Just a second. Okay, so welcome all of you and welcome to this session. This session is on the high topics of anatomy by me, Dr. Ankit Khandelwal, MBBS and MS in anatomy, and your anatomy educator for our Unacademy platform. So here's the session going on, and we'll be discussing few important topics from here. And let me just give you a highlight of what we are doing. Just let me check the sound plus. Yeah, sound is coming out. Everything fine, guys? Give me a thumbs up. Okay. So let's start the session. The session, as you can see, the high topic. So what I have discussed today or planned today are few of the topics from the abdomen, and then few of the topics from the upper limb. Few high topics. So no MCQs, nothing. MCQs already I'm having from the last 3 days daily 1 hour MCQs discussion, high MCQs, mixed bag MCQs. So this session is on your high topics. So relax and just chill down and see of the high topics, how much you are able to concentrate over there. And this is mainly high topics, right? So few things in the beginning, 20% off. Yeah, today is 30th of June, so few hours left for your discount, 20% off. You can use the code that is NPG10 written over here. Few other batches. For NEET PG batch coming up 2023, and you can see all the salient points. Let me read out. Well structured batch with all 19 subjects in depth coverage, 6 months subject wise, and 3 months of high revision batch. That's good. Good planning. NEET PG 2023 grand test and subject test available on the platform. Live interactive classes with the top educators, and recorded sessions are available if you miss the live classes. And these are the 2 USPs. PDF notes for the session, and practice question bank with 24,000 plus questions available. So a lot of stuff over here, and the batch is NEET PG 2023 test and discussion batch. So only a TND for those who have given the exams once. So the TND batch. So again, features over here. Finally, iconic prices. Iconic, I hope you guys remember that it was Unacademy and Pelvic combined. So their prices are going to increase soon. So you can hope to subscribe if you want to subscribe. It's the right time, probably the right time to subscribe. Clear? So again, let's come back to our topics, high topics, anatomy. As I told you, we'll be having some of the abdomen and high topics. So basically 3 images, and we'll be discussing those images. Let us start. Okay, here is the first image in front of you. The anterior trunk wall, or you can say the anterior abdominal wall. So basically it is the anterior abdominal wall and the anterior trunk wall. So anterior abdominal wall, basically what is shown over here is the cutaneous nerves which are supplying the anterior abdominal wall. So what you have to keep in mind over here, you can see that from T7 to T12 and plus L1, these are the cutaneous nerves, the thoracic spinal nerves and the L1, which are going to supply the anterior abdominal wall. So you can see around the umbilicus, it is around T10 which is coming. So they have the anterior cutaneous branches as well as the lateral cutaneous branches. So anterior cutaneous are rising from here, and the lateral is obviously from here. So this is the costal margin, as you can see, and the T7, 8, 9, 10, 11, 12 are coming from below, and 11, 12 from behind. The point over here is just to make you again revise that though we say it abdomen, but it is cutaneously, or the abdominal wall is supplied by the lower 6 thoracic spine nerves plus L1 to the groin region. That's the whole point. T10 around the umbilicus, T7 is around the epigastric region, L1 is at the groin region. L1 is also known as iliohypogastric, or its branch known as ilioinguinal nerve. Right. So what are questions they may come? See, questions can come from any format. There could be a surgical question when you are doing a midline laparotomy or a paramedian incision, and which nerves would be cut, would not be cut. A question like this. Then we also have to understand in this that the nerves over here they are not only supplying the skin. If someone wants to write in the comment box, what are they supplying? They are not only supplying the skin, but they are supplying from skin to the parietal peritoneum. Yes, this is the whole anterior abdominal wall. It arises starts from the skin. Then from skin it will go to the superficial fascia, then to the muscles, all the muscles over here, abdominal wall muscles, which includes the external oblique, internal oblique, transverse abdominis, and rectus abdominis. These 4 main muscles. So nerves over here will supply skin, superficial fascia, the muscles over here, fascia transversalis, and the parietal peritoneum. So all of that is supplied. What does that mean? That means that these nerves which you are seeing over here are actually the somatic nerves. So when any problem comes to the abdominal wall, it will be specific and localized. But normally there is a visceral problem like the appendicitis there, or the colitis is there, or gastroenteritis is there. So in that case the viscera is inflamed, so the pain is actually diffuse. But if that pain touches the parietal peritoneum, or the inflammation touches the parietal peritoneum, then the sensory part is carried by the somatic nerve, and then it becomes specific and localized. That is the whole point. So this image was just to advise you that point. I hope it is clear. Any doubt, let me know in the comment box. If you have any doubt, so I can just revise it. After this, we'll come to the next topic, and the next topic over here is this. I hope you all understand what this means over here. What is this? This is actually the inguinal canal. It is the inguinal canal. Beautiful image over here. Another high yield topic. You can see the inguinal canal, the spermatic cord coming out. The spermatic cord is coming out, and this spermatic cord is actually in males only, and that is being coming out from here through the superficial inguinal ring. So this is the right inguinal canal, and inguinal canal is an oblique. It is an oblique intermuscular passage. We all should know that it is an intermuscular passage, oblique. That starts from the deep ring labeled over here to the superficial ring labeled over here. It's an oblique intermuscular passage, right? The walls are actually shown over here just to review the whole inguinal canal, because inguinal hernias are very common. And what is over there? That you can see the inguinal ligament, which is formed by the external oblique aponeurosis. So this external oblique aponeurosis is the one that is actually forming the whole anterior wall of the inguinal canal. So anterior wall is external oblique aponeurosis. And if you look at the upper part of the picture, the fascia transversalis labeled over here, it is actually forming the posterior wall of the whole inguinal canal. So fascia transversalis over here and the external oblique over here. And if you see in between them, there are two more muscles, internal oblique and transabdominis, whose combined tendon is known as the fox inguinalis. That forms the roof. You can see they are moving over the spermatic cord, above the spermatic cord. So they form the roof of the canal. So just the boundaries over here we should be knowing, and how the canal is coming out. So if the hernia is coming out through this canal, in the comment box I need to ask you guys that would it be an indirect or a direct hernia? Inguinal, obviously. If the hernia is coming through the root of the inguinal canal, that is through the deep inguinal ring, through the whole passage, through the superficial ring, and going in females into the labia majora and males into the scrotum. So that sort of hernia, would it be an indirect inguinal or would it be a direct inguinal hernia? That is question number 1. The second question over here, the main point in this image is, if you look at the inferior epigastric vessels, you can see the top image. I don't know whether you are able to see the cursor. I am afraid you are not able to see the cursor over here, but I hope you can see the image. Inferior epigastric vessels is written just medial to the deep inguinal ring. So that is a landmark, inferior epigastric vessels. So look at the inferior epigastric vessels and also look at the muscle over here. Behind the superficial inguinal ring, you can see a couple of muscles. Rectus abdominis muscle, rectus abdominis. So if you take these two landmarks, the inferior epigastric vessels over the lateral side and the rectus abdominis muscles lateral border, rectus abdominis muscles lateral border on the medial side, and the inferior epigastric vessel on the lateral side, they form the Hasselbeck's triangle. A type of hernia arises from here, whose boundaries are inferior epigastric vessel lateral side, lateral border of rectus abdominis medial side, and base by the inguinal ligament. That is the Hasselbeck's triangle. And the hernia that is coming through this triangle would be the direct hernia. So Hasselbeck's triangle gives rise to direct hernia, and through the inguinal canal comes the indirect hernia. That's very important. I repeat again, the inferior epigastric vessels lie just medial to the deep ring, just medial. So if forms actually the surgical landmark, the inferior epigastric vessels. If tomorrow they ask you the inferior epigastric artery is a branch of, in that case your answer should be the external iliac. So external iliac is actually giving off the inferior epigastric. That is point number 1. But what is surgical landmark over here? It is that if the hernia is the mouth of the hernia is just medial to the inferior epigastric, it is direct. And if the mouth is just lateral to the inferior epigastric, that is through the deep ring, it is indirect. Yes, I repeat again that surgical landmark is this inferior epigastric vessels. Very important landmark. So in this image, actually I am fond of this image is simplicity. You can see the spermatic cord, you can see the spermatic fascias also. If you look at the lower right side of the image, it's written the external spermatic fascia, cremasteric fascia, internal spermatic fascia. These are all the coverings of the spermatic cord, or sort of coverings of the spermatic cord. And if you want to just remember what are they derived from, that also we can just go through it. That external splenotic fascia is coming from the external oblique. The cremasteric muscle and fascia is coming from the internal oblique. And the internal splenotic fascia comes from the fascia transversalis. Yes. The internal splenotic fascia is not from the trans abdominis. No. The internal splenotic fascia is from the fascia transversalis. Right. So these fascias, simplicity of the image, showing you everything over here, right from the Hasselbeck's triangle to everything. It's like a 3D and a 2D image, and giving you a fairly good simplicity. Also written the site of protrusion of diet hernia, site of protrusion of indite hernia. So yeah, let's revise this image. It will be highly beneficial for you. So the first topic that we did was the anti-abdominal wall and some of the nerves and things about it. Then the second is about the inguinal canal. And hernia, obviously. The hernia also, in the surgical part, you have to go through the names of the operations that are done for the hernia. Last year NEET PG they gave you 2021, if you remember. Come on, the next topic is this. Now what is this topic over here? Very simplified topic, nothing. Just a stomach image and showing you the parasympathetic nerve supply. Showing you the parasympathetic nerve supply. Now there is an anterior vagal trunk on the left side of the screen and there is a posterior vagal trunk on the right side. These are the vagus nerves which are forming the vagal trunk. The first question that arises, if you look at the left image, the anterior vagal trunk. If I may ask you guys, any one of you in the comment box, you may write that this is the anterior vagal trunk, is it the right vagus or the left vagus? The majority fibers of the anterior vagal trunk, they come from the right vagus or the left vagus. Which vagus nerve? That is question number 1. Second question is that you can see both the vagal trunks, they are giving gastric branches. Obviously, they are going to supply the stomach. So, they are going to give gastric branches. But which vagal trunk is going to give the hepatic branch and which vagal trunk is going to give the celiac branch, that you need to remember over here. So, either you can make a mnemonic that anterior goes to hepatic, or it is just common sense that if you open up the abdomen, the stomach is actually covered by liver anteriorly. Stomach is not on the left side separate, no, it is covered by the liver anteriorly. Liver lies anterior. So therefore the anterior vagal trunk gives rise to hepatic branches. I am still looking for the answer, guys. Anterior vagal trunk, it is the right vagus or the left vagus nerve? Think in the answer comment box. Come on. Don't worry, don't be afraid of getting it wrong. Attempt is more important. Okay. So attempting anything is more important, be whether you win or lose it. That's totally different. But your attempt with the full energy is the most important one. That is why I always say. So coming back, anterior vagal trunk is giving rise to hepatic branch because liver covers the stomach anteriorly, and the posterior vagal trunk is giving rise to celiac branches. Why? Because where is the aorta? Aorta is lying posteriorly. It is a retroperitoneal, and it gives rise to celiac trunk, and on which the nerve plexus are the celiac plexus. So definitely the stomach being an intraperitoneal and the aorta being a retroperitoneal, so the posterior vagal trunk will give the celiac branches. Then there are other nerves like nerves of Lataget and nerves of Gracie and all. But remember just this image, basics. To let you know that anterior vagal trunk gives a hepatic branch, posterior vagal trunk gives a celiac branch. And I'm still waiting for the answer, guys. The anterior vagal trunk is basically the left vagus nerve. Left vagus nerve, yes. Anterior, the left vagus nerve basically forms the majority of the anterior vagal trunk, and the right vagus nerve forms the posterior vagal trunk. I repeat again, the left vagus nerve will form the anterior vagal trunk mainly, and the right vagus nerve mainly forms the posterior vagal trunk. Clear? So this was the point which I wanted to revise you guys from this particular image only. That's it. So these are high yield topics, short topics, and we'll move to the next one. Here it is, the next one. Okay, so same thing. The stomach you are seeing, gastric is the stomach over here. But here what you are seeing are the various sort of ligaments being shown over here. Various ligaments are shown over here. What are those various ligaments? On the lesser curvature of the stomach, lesser curvature, you are seeing the lesser omentum on the left side of the screen, and you also can see there are two arrows. Excuse me. There are two arrows from the lesser omentum, that is the hepatogastric and the hepatoduodenal ligament. There are two parts, hepatogastric and the hepatoduodenal ligament. Obviously, needless to say, hepatogastric is from liver to the stomach, that is lesser curvature, and hepatoduodenal is from liver to the first part duodenum, that is lesser omentum. It is on the lesser. So what is important in this? It is known as lesser omentum, fine, but what is important is that as we saw that the left vagus nerve moved anteriorly, so the anterior, the ventral mesogastrium will move to the right side. So what you are seeing, the lesser omentum, please 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 understand the lesser omentum over here is actually a derivative of ventral mesogastrium. Please write it. I'll be speaking it once more. As the left vagus moved anteriorly, so the ventral mesogastrium moves to the right side. So lesser omentum is actually derivative of, write down LO is a derivative of ventral mesogastrium. That is the point. Now, if you look on the greater curvature of the stomach, all these ligaments, gastrophrenic between the stomach and the diaphragm, the gastrosplenic between the stomach and spleen, the greater omentum, these are all derivatives of the dorsal mesogastrium. So all the derivatives or all the ligaments attached to the greater curvature are actually dorsal mesogastrium derivatives. And anything which is attached to the lesser curvature, like the lesser omentum, is actually derivative of ventral mesogastrium. Please note it down, it is very important, because nowadays questions are coming from here. And remember, these, when we say the ligaments, these are all double fold. So they have vessels, they have the lymphatic nerves between them. Tomorrow they can ask you the contents of them. Let me just rephrase it so that you may write if you want to. The lesser omentum contains what? Anyone? I know there's some lag, but still. The lesser omentum contains what? The right and left gastric vessels. The right and left gastric vessels. The greater omentum contains what? The right and left gastroepiploic vessels. The right and left gastroepiploic vessels. The gastrosplenic ligament contains what? The short gastric and the left gastroepiploic vessels. And the gastrophrenic ligament may contain some short gastric vessel branches. There is also one more ligament which is not shown, but it is lying more posteriorly. It is between the spleen and the kidney. Which kidney? Right or left? If you are thinking left, correct. Between the spleen and the left kidney, there is one more ligament known as the splenorenal or linorenal ligament. That is also important. It is also derivative of the dorsal mesogastrium. But the question comes that what is contained in that ligament, or what is the content of that ligament? The linorenal. It is the splenic vessels and the tail of pancreas. Splenic vessels, that is splenic artery, splenic vein, and the tail of pancreas, which lies in the linorenal ligament. So linorenal ligament is that. Gastrosplenic is short gastric vessels and left gastroepiploic. Greater omentum is right and left gastroepiploic, and lesser omentum is right and left gastric. Plus, in the lesser omentum we have missed one thing. What is that? The right margin of the lesser omentum. A part of the hepato, you can see just the right margin of the hepatoduodenal ligament, that part. Remember, in this double layered fold of peritoneum, it is containing the portal triad structures. Yes, portal triad, I hope you remember, portal vein, hepatic artery, and bile duct. So that is also a part of the lesser omentum, or you can say the right margin of the lesser omentum. So this image becomes important. I just told you that what are the derivatives of ventral. So just to revise, anything to the attached to the lesser curvature is actually ventral mesogastrium derivative. Anything attached to the greater curvature is actually the dorsal mesogastrium attachment, and in continuation to it. That is the bottom line. This image I place for that part. Let's move to the next image over here. So these 2-3 things we have done. Move on to the next one here. Same thing, nothing new in this. But just to see, what you can see is, can you see the two retractors shown at the top of the image, which are retracting the liver? Now just imagine if the retractors are not there. Would not the whole stomach be covered by the liver? If you remove the retractors, the liver will fall down in front of the stomach. Right? That is what I told you, that the liver is actually covered up by the stomach. So here what you see is the lesser omentum as shown, and the right margin is being dissected out. You can see the right margin or the right part of the lesser omentum being dissected out, and you can see the bile duct. You can see the artery, the red color artery on the left side, duct on the right side. Can you see the faint blue color posteriorly? That is the portal vein. So these are the arrangement of the three structures in the right margin of lesser omentum. And I hope you can visualize one more thing. What is that? This is the right free margin of lesser omentum. What is just behind this is a foramen. I hope you guys revise it and remember it. It is epiploic foramen. Just behind the right margin of the lesser omentum is the epiploic foramen. It is also known as the foramen of Winslow, W-I-N-S-L-O-W. And epiploic is E-P-I-P-L-O-I-C. So it is just right behind the right margin of lesser omentum, and it is a connection between the lesser sac, the cavity behind the stomach, to the greater sac, the general peritoneal cavity. The epiploic foramen as a topic is important. So just 2-3 points of epiploic foramen. Anterior to the epiploic foramen are the portal triad, as what you can see. Below it is the first part duodenum. Above to the epiploic foramen is the caudate lobe. But which vessel lies posterior to the epiploic foramen? In the comment box, if any one of you can write it. Maybe later also, don't worry. What lies in the posterior wall of epiploic foramen is a vessel, and that is IVC, the inferior vena cava. That is the posterior boundary. So epiploic foramen is surrounded by important structures. That's the whole point. Clear? Let's move from this image. I guess greater momentum also you can see the spleen also. Let's see the next one over here. Okay, here it is. What is this? Hydrocele. You can see in the upper image there is a testis shown, which is covered by this whole epidermis, and the vas deferens is this S sigmoid shaped vas deferens shown. But can you see the acquired hydrocele written over here? That is a fluid inside the tunica vaginalis. Tunica vaginalis. See, testis covered by the derivative of the peritoneum, that is the tunica vaginalis, which has a parietal layer outside and the visceral layer which is in touch with the testes. Simple as that. And the space between them, if the fluid fills it, it's known as acquired hydrocele. The lower image is shown a cannula that is entering and draining the hydrocele fluid, the fluid of hydrocele. Now they can give you an image, or you should be knowing it, that what are the layers which this instrument, cannula or needle pierces before it reaches the fluid of the hydrocele. So from outside, if I start discussing the skin, obviously, then in the skin of the scrotum you have the dartus muscle, which is derivative of or continuation of the superficial fascia, dartus muscle. So you can see below the scrotal skin, dartus muscle. Then there is this scarpas or membranous layer. Then after this we discussed in the first image or second image to be more precise, the covering of the spermatic cord were external spermatic fascia, cremasteric and internal spermatic fascia. These are three fascias. External spermatic fascia, then cremasteric, then at the bottom side you can see the internal spermatic fascia. These are derivatives of I already discussed with you. External spermatic from external oblique, cremasteric from internal oblique, and internal spermatic from the fascia transversalis. And then you have the layers of tunica vaginalis. These are the layers: skin, fascia, muscle, all the three fascias, and the parietal layer of the tunica vaginalis. And after that you enter the fluid of the hydrocele. So this the layers over here showing you, and just quick revision. Next quick high topic over here, and quick revision. The same thing but in the abdomen. You can see two needles over here, number 1 at the left side and number 2 on the right side. They are passing through, and where they reach again in the peritoneal cavity. Just like in the previous image, they went to the hydrocele fluid in between the parietal and visceral layer of the tunica vaginalis. Here the needle is going into between the parietal and visceral layer of the peritoneum. Just the difference is the needle number 1 is going through the midline, and needle number 2 is going to the lateral abdominal wall, anterior lateral abdominal wall. So in the needle number 2 is normal. It passes through the skin, the superficial fascia, the scarpas, external oblique, internal oblique, transverse, fascia, transverse, everything. That is normal. But if the needle is made to pass through the midline, then the only change over here is that the skin, fascia, everything is fine. The peritoneum and all is same. The fascia transversal is also same. But in place of these three muscles, external oblique, internal oblique, and transverse abdominis, in the midline there is a linea alba. That is the aponeurosis. They crisscross in the midline. Three muscles on the lateral side, their aponeurosis, they crisscross in the midline. So in place of these three muscles, what is written over here is only linea alba. That is only difference. Whereas all the things are nearly the same. All the things are nearly the same. Okay. This was one another high topic. Okay, let's move on to the next one. Okay, here it is. Yeah, here it is. Again, a polite part, but what is shown over here? Okay, good evening all of you again, and settle down fast. So we have, I guess with this is 7th or 8th image. We are just rushing through the images over here as much as we can. So this is an image, as you can see, the varicose veins on the anti-abdominal wall. So we have seen varicosity on the lower limb veins, but this is on the anterior abdominal wall. What is the reason for this? Probably it is due to IVC obstruction. Could be SVC also, mainly it is IVC obstruction. Okay, SVC, IVC obstruction, something like this. So in the portal hypertension, you see caput medusae, the veins radiating out from the umbilicus. That is caput medusae, different thing. Here you are seeing a thoracoepigastric vein dilatation. Thoracoepigastric are two words, thoraco and epigastric. The thoraco word is coming from some thoracic vein on the thorax. That is probably a lateral thoracic vein. The epigastric is this vein written superficial epigastric vein that may go to the ultimately go to the femoral vein via the saphenous vein or anything like this. But see, superficial epigastric vein, as it goes below, crossing the inguinal ligament, it is superficial only. So it may pass via the great saphenous vein into the femoral vein. So these veins, they anastomose and the blood is shunted from above below or below above in case of SVC or IVC obstruction. So this is known as a thoracoepigastric vein dilatation. Okay, just look at the image. And also remember the caput medusae are the veins radiating out from the umbilicus. That is caput medusae. Next image over here. Yep, here. Not last, but this year only. Last month. Not last year, last month. Exam questions. This is the transverse section. And you can see the liver, the stomach, the spleen, the kidney, and the aorta ibis. These 4-5 structures are given over here. 4-5 structures are given over here. It is like a TS and you are looking from above. Remember, see, the orientation is very important. Normally, if it was a CT scan, then the left side of the screen would be the right and the opposite. So you know how do we visualize the CT? But it is in CT, it is the TS you are looking from below, and this image it is TS and you are looking from above. That is only point. Here you can see the stomach and the space behind the stomach. This blue marked space is the lesser sac, and the anterior part, that is whole the greater sac. Anterior part is anterior to stomach. The whole cavity is the greater sac. Now can you see a arrow over here, a curved arrow, and the right side on the lower part you can see epiploic foramen. That is connecting the lesser sac behind the stomach, the blue colored area, to the greener area, that is the greater sac, epiploic foramen. Right? Aorta you see, you can see on the left and right side, and the kidneys you can see over here, and the spleen also. Spleen is intraperitoneal, as you can see. It is totally covered up by the peritoneum, intraperitoneal. So spleen, stomach, liver are intraperitoneal. Kidneys, aorta, IVC are retroperitoneal. Right? And what are the derivatives of ventral and dorsal mucosal that we already have discussed, so you can have a look at that. Okay, so this image just to have you can have a look at that. Moving on to some other points. What is this? The liver part. What is this? Liver segments are shown. Hepatic segments, and you can see below it right lobe and left lobe are written. But that lower classification is not from the falcium ligament. The lower classification is not from the falcium ligament. It is from this Cantley's line. That's from gallbladder to the IVC. The fossa of gallbladder to the IVC, that is the Cantley's line. So right of it is the right lobe and left of it is the left lobe. But look at the names over here. The name of segments. On the right lobe, if you see that the anterior superior area and anterior inferior areas looks okay. But you can see the posterior superior, posterior inferior. So basically the right border of the liver is so much rounded. That the anterior, it is right into anterior posterior. It may look like middle little, but it is basically anterior posterior. And if I may tell you over here that the number of segmentation is also very important. Left lobe has segments from 1 to 4 and right lobe has 5, 6, 7, 8. The anterior inferior, this you can say the light brown color is segment number 5. The posterior inferior is segment number 6. The posterior superior is segment number 7 and the anterior superior is segment number 8. 5, 6, 7, 8 on the right lobe. Now to come to the left lobe. Here's one more interesting point. In left lobe, you can see it divided mainly by the falcium ligament into medial lateral segment. Please understand which is medial, which is lateral segment. The left you can say the left extreme of the liver. There is a tapering point of this left lobe. That is the lateral segment. And at the middle is the medial segment. So medial superior, medial inferior, that is the quadrate, segment number 4 in front. And lateral superior, lateral inferior, they are segment number 2 and 3. Where is segment number 1? That is actually present behind as a quadrate lobe. So segmentation over here, just wanted to show you segmentation. And in that segmentation which is anterior, which is posterior, which is median, which is lateral. Have a look at it. This is an image important. Please. One more image from the liver. I guess we have there. That is the visceral surface of the liver. So why is this image you showed? Because I wanted to show you two things in this image. That first of all, it is a visceral surface. So you're looking at a posterior inferior aspect of the liver. Now please understand, when I say any term in anatomy using the medical terminologies, you have to understand it. I said you are looking at a posterior inferior aspect. You are looking from the posterior inferior aspect of the liver. Suppose some person is standing in front of you, or you can say you are standing behind a person. Simple. And you know that if you visualize the liver of the person, this is the posterior surface. But you are looking from posterior inferior side. So what you visualize over here is first of all the relations. Liver is related to the right kidney. You can see the renal area and the right colic flexure. Remember, the ascending colon becomes the transverse colon. So kidney and adrenal relations are very important. as you saw that liver was covering the stomach on the left side. So this left lobe, particularly to the left of this whole ligament, is the relation to the stomach and continues as the pylorus and duodenum. These are the relations. But more than this, what you are seeing the IVC, you are seeing the gallbladder. Imagine IVC and gallbladder to be one vertical line. Imagine. Then imagine this fissure for ligamentum teres and fissure for ligamentum venosum to be another vertical line. So there are two parallel vertical lines. On the right side is IVC and gallbladder, on the left side is ligamentum venosum, ligamentum teres. And connecting these two vertical lines is the horizontal, that is porta hepatis. Can you see the porta hepatis right written at the lowermost part of this image? Porta hepatis. So you have two vertical lines and two horizontal lines, they form H. That is known as H-shaped fissures. H-shaped fissures. And between this H, upper one and lower one, upper part is known as caudate lobe, lower part is known as the quadrate lobe. So caudate and quadrate. Remember this H-shaped, I always keep on saying remember the H shape. If you remember the H shape, it will be okay. So I'll repeat once again, the right side vertical line is actually the IVC and the gallbladder. Left side is the ligamentum venosum and ligamentum teres, and connecting them is the porta hepatis. Caudate and the quadrate lobe. Right? So caudate lobe over here between the IVC and the fissure of ligamentum venosum is the segment number 1. And to the right of IVC and gallbladder, everything is the right lobe. Everything is the right lobe. I hope it is somewhat clear. Okay. Just listen to my words carefully later on if you have any confusion, and you will get to the point. You can also ask questions, doubts in the comment box. I will try to help you out over here. Next image after this is this, the relations. Why is this image? This image may look simple and sort of obsolete, if I may use that term, but it is very informative. Very informative. What is shown over here is from, if we move from posterior part, we are seeing the IVC and aorta, and in the portal also is what you can see in front of IVC. Then you are seeing the duodenum curvature, C-shaped duodenum, and the pancreas. Fine. What you are looking is actually all the retroperitoneal structures. The duodenum, the pancreas, aorta, IVC, they are all retroperitoneal structures. Fine. But the important part is not this, the vertebral levels written on the right side. Right. Now, if you look at the T12, and that is going where above the duodenum. So the epiploic foramen, if you remember, it was just above the duodenum. Vertebral level is T12. Vertebral level is T12. Then you can look at the L1. L1 is a transpyloric plane. You can imagine the pylorus part of the stomach at that plane. And also at that level L1, there are many things at the transpyloric plane. If I may revise a few, then at L1, let me tell you the transpyloric plane, the lower part of L1 to be more precise. What is happening is the origin of the superior mesenteric artery. Right, origin of superior mesenteric artery. Then let me revise. The hilum of the kidneys are present over there. In adults, the spinal cord ends over there. Right. The portal vein is found behind the neck of pancreas at that level. Right. So these are few things, and other things also would be there. Transpylorus, so pylorus lies over there. If you guys can remember any other thing, then fine. Transpyloric plane, very important. Fossa for gallbladder lies over there. Tip of the 9th costal cartilage lies over there. So other things are there. So transpyloric plane is a very important plane. Then look at L2. Below L1, L2. L2 is around the second part of duodenum. But about L3 is at the third part of duodenum. The C-shaped duodenum, first part horizontal, second part vertical, third part again below horizontal, fourth part is slightly above. So remember, the L1 is first part duodenum, L1 is first part, L2 second part, L3 third part duodenum. And L4 again slightly rises above, and L4 on the fourth part duodenum again goes to L2. So L1, 2, 3, D1, D2, D3. And then D4 is again moving to L2. So vertebral levels are important over here. That is why I kept the figure there. Right? Let's see one more again. Now here, very, very important slide concerning your recent exams. Why? The last couple of years, they have asked a lot of questions related to this image. Therefore, I urge all of you to go through this image in detail. In the outer part of this image, you can see superior borders written, below inferior borders written, and anterior borders written. All the attachments are being written over here. It is a pancreas, and you can see its superior border, what is lying is splenic, celiac, and hepatic artery. See how important structures are there. Questions come in variety of ways, like there is a surgery being done on the upper part of the pancreas, what vessel could be injured, and blah 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 like that. And look at the anterior border. Can you see a blue line and the green line? Blue is actually the part of the pancreas which is above the attachment of transverse mesocolon. So gap between blue and green on the anterior surface of the pancreas is actually the root of transverse mesocolon. So above it is the suprachole compartment, below is the infrachole compartment. Right? So anterior border, attachment of the transverse mesocolon. But if you look at the inferior border of the body of pancreas, and from there the superior mesenteric vessels are coming out. And they go in front of uncinate process. Please understand that also. So I guess last year question came about the tumor around the uncinate process and which vessel can be injured. It is a superior mesenteric vessels. Other vessels you also can see. You can see the tail of pancreas going to the hilum of the spleen, and other many things are there. But yeah, the attachments, the surrounding structures, the relations of the, because see, pancreatitis itself is quite common, and both acute chronic are there. Pancreatic cancer is also not that uncommon, so that can also be asked. It being a retroperitoneal organ, so the inflammation over here, it goes to other areas behind the peritoneum or may go into the peritoneum also. So important part, so important image, so I placed it over here. Next topic, okay, simplified, very much simplified. Just a continuation of the previous image. Previous image was this over here, and current image is this. See, again the pancreas and duodenum are shown over here also. You can see the splenic artery and the superior mesenteric vessels are also shown. That is what you see. But here, beautiful image. Why? Because if you look at the whole image, then apart from the spleen that is shown at the right side of the image, all the other structures are retroperitoneal apart from the spleen. Look at their individual relations to each other. Pancreas is passing in front of left kidney. Look at it. Visualize it. And in front of the pancreas would be the peritoneum, and in front of that it would be the stomach. So the pancreas, the left kidney, the left adrenal, the aorta, the part of spleen also, they are all part of the stomach bed, the bed of stomach. And look at the, visualize, look at the second part of duodenum, the curvature of duodenum, second part, no, where the head of pancreas coming, second part duodenum. It is in front of what? Which structure? The hilum of right kidney. What? The hilum of right kidney. So D2. The second part duodenum is in front of the hilum of right kidney. Look at the relation. Why these relations are important? Because any problem in the duodenum or the kidney may trouble each other. All are retroperitoneal except the spleen. Look at the aorta IVC and visualize where would the renal vessels be into the hilum. So in the hilum of the kidney, the veins are anterior. Vein, artery, pelvis, if you remember, anterior to posterior. So renal veins are more anterior, then comes the renal artery, then behind it comes the renal pelvis. So structures at the hilum. So interpersonal relations, or relations of the inter-organs. This slide gives a good command onto it. Next picture over here. Okay, another frequently asked. I hope you can see the pyelogram over here. With everything labeled over here, you can see the calyces, the ribs, and the ureter outlined below into the bladder. 1, 2, 3, the red color labeling are shown, and I hope you can understand that what they mean, that the normal areas of the ureter constrictions. So the stone, it's very common, I hope you all know, that the kidney stones, they are common, and they drop down into the ureter, because ureter stones are normally secondary stones, they are not primary. Primary stones are found in the kidney only. So kidney stones, they fall down into ureter, and these are the areas of constrictions 1, 2, 3. What is one? The pelvic ureteric junction, where the renal pelvis becomes a ureter. There is a slight kink over there, slight constriction. The stone may lodge over here. So, and remember the normal diameter of the ureter is around between 3 or 3 to 4 millimeters. That is all. So the stone is more than that, then size of that, then chances are good that it may be lodged or may get trapped into that constriction. So number one constriction is the pelvic ureteric junction. If you see number 2, below number 2, both in the pyelogram and also in the drawing over there, that is where the ureter is crossing in front of the common iliac artery. I repeat again, ureter crosses in front of common. I want you to write over here, whoever is listening right now, maybe later on, that please note down the ureter crosses in front of the common iliac artery. And second point is that ureter is crossed anteriorly by the gonadal vessels. So gonadal vessels will pass in front of ureter, and ureter passes in front of the common iliac artery, and when it passes in front of common iliac artery, the second constriction is more likely to be there. That is the second part of constriction. The third part of constriction is when the Ureter is actually sort of, you can say, the entering into the bladder. That is the third part of constriction. So these are the spaces where the stones which are falling down from the kidney may get trapped. I mean, if everything is good, then they will pass into the bladder without causing much pain, and then they may come out also. If the size is less and the conditions are good. So if we all know the patient is advised to drink a lot of water over here. So there's more flow of urine and the stones does not get trapped. So this image was important and just showed you over here, and come to the next image over here. What is this? Pelvic diaphragm. Yes. It is supporting the pelvic viscera. So where is pelvic viscera? Viscera has been removed. The upper part of the image you can see is the sacrum, that is the posterior part. Upper part of the image is the posterior part of the picture over here, or the bony pelvis over here, and the lower part of the image is the pubic symphysis, that is the anterior part. So that is your pelvic diaphragm. And now what are the muscles in the pelvic diaphragm? If you move from anteriorly, that is the lower part of the image, there is pubococcygeus. Go from anteriorly, that is the lower part of the image, into the coccyx, pubococcygeus. Then you have the iliococcygeus behind it, and most posterior, or second last to posterior, is the ischiococcygeus. In the upper part of the image, you can see two pair of nerves coming out. They are actually the sacral nerves, and just lateral to those two pair of nerves, you can see a muscle, that is piriformis or piriformis. That is not a part of pelvic diaphragm. No, piriformis, I just wanted to localize you guys, is not a part of pelvic diaphragm. So below it, all the muscles are part of pelvic diaphragm. They are supporting the pelvic viscera. Viscera has been cut over here. You can see from the lower part of the image, you can see a rounded urethral opening in the midline. Behind it, you can see the vaginal opening for the females, and behind it, you can see the rectum continuing into the anal canal. So these are the pelvic viscera which are above it. They have been cut to show you the diaphragm. So this is the pelvic diaphragm. From below upward in the image, pubococcygeus, iliococcygeus, and ischiococcygeus. But if they ask you about the levator ani, only the lower two muscles will be there in the levator ani, that is the pubococcygeus and the iliococcygeus. They are a part of levator ani. Ischiococcygeus is not a part of levator ani. Please remember that. Right? So this is just a muscle to show you the pelvic diaphragm, and they are supporting the pelvic viscera. There is no muscle between the abdominal viscera and the pelvic viscera. There is no diaphragm between the abdomen and pelvis, but this is the diaphragm which is supporting the pelvis. So it is actually between the pelvis above and the perineum below. But there is no such diaphragm between the abdomen and pelvis. What is there between them is probably a fold of the peritoneum, that you can say is there, but not the diaphragm. Remember that. Moving on from here, simplified table, anterior and posterior. If you look at this table and just think about it and write in the comment box if you can that it is probably showing you branches of which artery. Anterior trunk to lower limb, obturator, inferior gluteal, perineum, internal pudendal to pelvic viscera, superior vesicle, middle rectal. In males, there's females, there's posterior trunk, these branches. So these are the branches of a vessel which is supplying the pelvis and the perineum. And the vessel over here is the internal iliac artery. Why have we placed this image? Because normally we forget the internal iliac artery, to be very frank. What are the branches of it? Remember, the internal iliac artery as a whole is actually supplying the pelvis, and a branch of it will supply the perineum also. That is the whole point. So basically pelvis and perineum, if you remember what are the organs over there, the names of those will be the arteries. Now why anterior posterior trunk? Again, how easy to remember it? See, posterior trunk is obviously lying posteriorly, and as the common iliac artery is posterior, the internal iliac artery is posterior. So when the posterior division of the internal iliac artery comes, it is actually most posterior. So it supplies what? The lumbar area, the sacral area. The lumbar sacral are basically lying posterior, the superior gluteal area. These are branches of posterior trunk. Rest all the branches you can see are branches of anterior trunk. Now, it not only supplies the pelvic and the perineum, but it will also supply what? It will also supply the lower limb. You can see the lower limb, obturator and inferior gluteal. See, gluteal region as a whole is a part of lower limb. Remember the obturator artery. It is very important artery for the small children because it gives a branch to the head of the female. So this table is important because we have divided this table into lower limb branches, to perineum branches, and to the pelvic viscera. So if you read them twice or thrice, then slowly and by understanding, no one is going to dare stop you from recalling it. That is the reason why I place this image in the highlighted topics. Quickly moving to the next image. Again, a simple image. I hope you all must have seen this. And very simple: anteflexion and angle of anteflexion and angle of anteversion. Just remember the vagina and the cervix. The angle is version. Vagina, V for vagina, V for version. Angle between the long axis of cervix and the body is the angle of anteflexion. Angle of anteflexion. Okay, angle of anteversion and angle of anteflexion. Very important to understand. Angle of anteversion, that is around 90 degrees. Angle of anteflexion, that is between the cervix and the body, is 170, is 175, something like that. So quite a big angle. Or you can say the bend is very less between the cervix and the body of the uterus. Bend is very less. Bend, right? Okay, so this was the angles, and one more image I guess we have over here. Yes, perfectly. See, 4 subtypes are shown over here. First is normal. In the upper left side of the screen, you are seeing the normal side. That is anteflex, anteverted. But now you see the second image, and by hiding what is written over here, should tell me it is anteversion or retroversion, anteflexion, retroflexion. So B image, you can see the cervix vagina angle is fine, so it is anteversion, but the body and the cervix angle is opposite, it is retroflexion. The C image, the lower left image, angle of cervix vagina is opposite, so it is retroversion, but angle of cervix and body is okay, so it is anteflexion. Same for the last image, I mean both sides retro. Manoj, I am using, but it is not being used over here. I am trying over, but it's not being used. So something will be used. I know, and from the beginning, it is hard, more than 40-50 minutes. Therefore, I am saying it slowly. And if any doubt, write in the comment box. I will try to sort it out. Pen is not being, used over here in this particular session. But don't worry. For the next session, there will be pen and all. But certainly, it was not able to use over here. Okay. Next image over here, and just a second. Yes, now we move to the upper limb. Just a second. Yeah. So these are few images of the abdomen part, the uterus, the internal iliac artery, the pelvic diaphragm, the ureters, the relations, the pancreas, the vertebral levels, the livers, the segments, the peritoneums, the IBC obstructions, the abdominal wall, the hydrocele, quite a lot of topics, laceromentum, all the derivatives of mesogastrium, the vagal nerves, the inguinal canal, and the anteabdominal. So around 15-20 topics we have done. Now some topics from the upper limb also. 4-5 topics we should touch from the upper limb, and just rapidly coming and came. Simplified. What is this? You are being shown a humerus as a bone on the anatomical aspects of humerus bone. No need to worry for that. On the right side of the screen, what you are seeing are the 3 nerves labeled as axillary, then radial, and below is the ulnar nerve. Axillary, radial, and the ulnar nerve. 3 nerves are being shown over here, and the point over here is that these 3 nerves are in close approximation to the periosteum of the bone. So any problem in the surgical neck of the bone or dislocation of the shoulder joint may damage the axillary nerve. The radial nerve is passing through the radial groove, so any problem in the shaft of the humerus may damage the radial nerve. And finally, ulnar nerve is passing behind the middle epicondyle, so any problem in the middle epicondyle may damage the ulnar nerve. So this is the 3 nerves which are in close approximation to the bone. That is the point. One more image over here. Again, for the quick revision, we have over here the bones, but not the phalanges or the metacarpals that we know. The counting has to start from the thumb, but the carpals over here. Look at the carpals labeled as TZ, T, S, C, H, L, P, and TQ and all that. But below this, look at the radius and ulna. Focus and try to understand whose lower border is more broad or whose lower end is more broad. Radius or ulna? It is the radius. Radius lower end is more broad, so that is the lateral side. So then you start with the mnemonic that she looks too pretty, try to catch her. So scaphoid, lunate, tricotyl, pisiform on the proximal row, trapezium, trapezoid, capitate, helmet on the distal. Just this image for you to visualize and understand the carpals. Because tomorrow there can be a question, putting an arrow on any carpal and asking you to identify this carpal. That could be a potential question. Same for tarsals also. Next image over here, and that is what? That is the, you can see the scapula. It is which side is scapula? Right or left side is scapula? I can see it is the right side is scapula on the anterior view. This is the anterior view. On the right side of the image, you are seeing 2 vessels named as dorsal scapular and suprascapular artery. On the left lower side of the image, you can see the lower side of the image, you are seeing the subscapular and the circumflex scapular, thoracodorsal arteries. This image is showing you the anastomosis around the scapula. Right? So when the axillary artery that passes in front of the scapula, in front of the subscapularis muscle. When it gets obstructed, then these vessels, dorsal scapula, suprascapular, these are branches of subclavian. Then anastomose with the subscapular, circumflexscapular, which are branches of the third part of axillary. This anastomosis happens around the scapula. So that if there is axillary artery constriction, the blood from the subclavian may bypass the constriction through the scapula into the upper limb. Else see, the only artery entering the upper limb is brachial artery. In lower limb, if I ask you the only artery entering the lower limb, you will probably focus on femoral artery. Though obturator artery is also there, and the gluteal artery is also there, which anastomose, there is a lot of anastomosis. But here in the arm, it is only the brachial artery. Continuation of axillary artery that is going on. So to maintain the blood supply to the upper limb, this anastomosis is very important around the scapula, and frequently asked question. Right? Anastomosis around the scapula. Next image. One more anastomosis, don't get afraid by this. This is the anastomosis around the scapula. Around the elbow. Scapula was the previous one. This is anastomosis around the elbow. Now what to see over here, there are many labelings, don't worry. Focus only on at least the branches which are forming the anastomosis. You are seeing the very thick brachial artery over here, very thick brachial artery, right? This is a very thick brachial artery over here. Sorry. Just a second. Yeah, very thick brachial artery over here. And this very thick brachial artery, it divides into radial and the ulnar artery. You are seeing the lateral radial and the medial ulnar artery. Brachial artery is given from above superior ulnar collateral artery and inferior ulnar collateral artery. Superior ulnar collateral artery passes behind with the ulnar nerve. So please write it down. The superior ulnar collateral artery, SUCA, SUCA. It passes with the ulnar nerve. Inferior ulnar collateral artery passes in front of the medial epicondyle, and the inferior ulnar collateral artery, IUCA, is also known as, please write down, the IUCA, inferior ulnar collateral artery, is also known as supratrochlear artery. Right? So these are the few things that you can remember from this image. There are various labelings. You can have them later on also. Let's go through them. No need to worry. Now one more slide over here, and what is it showing to you is the brachial plexus. No, we are not dealing with the brachial plexus as a whole. It's a whole big topic. No need to worry about the whole topic over here. But what you are seeing is the C5, 6, 7, 8 and T1, they are from the brachial plexus, the roots. They form the three trunks, then the division, then the cords. But what comes out of the cords are, you can see in the right side, please memorize these 5 nerves. These are the 5 terminal nerves. The musculocutaneous, the axillary, the radial, the median and the ulnar nerve. So out of the whole brachial plexus, it is these 5 terminal nerves, they are the ones which actually are continuation of the brachial plexus, and they supply the whole of the upper limb. That is distal to the shoulder joint. So before the shoulder joint, or proximal to the shoulder joint, this whole pectoral region and the scapular region and the shoulder region. So various nerves supply there. So the distal continuation are into the arm and forearm. So you can see musculocutaneous supplies the entire arm. Axillary nerve supplies the deltoid muscle, which is actually covering the shoulder. Radial nerve is supplying whole of the posterior aspect. Median and ulnar, they supply the median mainly forearm, and ulnar supplies the hand muscles, palm muscles. These are the 5 terminal branches of the brachial plexus, which are very, very important. 5 terminal branches of brachial plexus. Brachial plexus as a whole topic is very important. Every aspect of brachial plexus has been asked in exams. We are not sure which aspect will be asked, so it's better to revise it. Go through this topic. All the topics that we discussed today, I'll just go through them in just a span of a couple of minutes in the last couple of minutes. All these topics, they are so important, you actually cannot afford to miss them. Just a few glimpses of those topics. A couple of tests over here. Identify if this test is testing which nerve, or it is the test to test the integrity of which nerve. You are holding a piece of paper, you ask the patient to hold a piece of paper with the thumb and the index finger, and then you try to pull the paper, and you ask the patient to resist the pull, or to resist the paper from getting out from his or her hand. He will try to adduct the thumb to the index finger, or the side of the index finger. And this movement is which movement of thumb? Thumb coming close to the lateral border of the hand. It is which movement of the thumb? That is the adduction of the thumb. So basically you are testing the adductor pollicis. Adductor pollicis is a muscle supplied by the ulnar nerve, deep branch of ulnar nerve. So if the ulnar nerve is fine, it is okay. But if the ulnar nerve is damaged, so this foramen test is basically testing the integrity of the ulnar nerve. So now if the ulnar nerve is damaged, you can't adduct it, so you have to slightly flex the interphalangeal joint of the thumb, that is FPL muscle, because FPL is supplied by anterior interosseous nerve, median nerve. So if the ulnar nerve is damaged, adductor is not possible, then the patient will obviously unconsciously or subconsciously will flex the interphalangeal joint of the thumb, and that will be the Fromen's test procedure. So it is a test basically to test the integrity of the ulnar, right? Finally, we're coming to the end of it, and these are some of the spaces around the scapula, spaces. Look at the spaces written over here. There's a quadrangular space being labeled over here, and the two triangular spaces labeled over here. The quadrangular space just below the teres minor is actually adjacent to the surgical neck of humerus. So if you know what is there in the surgical neck of humerus, then you will be sure that what are the contents of the quadrangular space. Simple as that. If you look at the lower triangular space, it is in continuation to the spiral groove. So the lower triangular space is basically having the radial nerve, because spiral groove has the radial nerve and the profunda brachii vessels. So lower triangular, it is the radial nerve and the profunda brachii vessels. The quadrangular space close to the surgical neck is having the axillary nerve and the posterior circumflex humeral vessels. And the upper triangular space is basically having the circumflex scapular vessels. So look at the spaces, and they are bounded by which muscles? The muscles mainly are two teres, minor, major, a long head of triceps, and a humerus. So these are the few things which you can remember from these spaces, right? So these are few topics. If I go back over here again, let me revise all these topics for you in just less than a minute. Here we start over here. Anti-abdominal wall, high yield topic, very high. Look at the nerves, the dermatomes. Inguinal canal, you can't miss. Out of 10 exams, 9 exams, they will ask you inguinal canal and hernia. Mark my words. Very simple image, just confusion that which is the anterior posterior vagal trunk, and which vagal trunk gives the hepatic or the celiac branches. Anterior gives the hepatic and posterior is the celiac. Left vagus is the anterior and the right vagus is the posterior. This question has started coming in this image. The derivatives of the ventral and the dorsal mesogastrium. So lesser curvature is ventral mesogastrium, and the greater curvature attachment is the dorsal mesogastrium. Look at the retracted liver and the portal triad structures in the right margin of lesser mentum. Layers of the scrotum in continuation with the abdominal wall. These are the layers that have to be pierced to drain the fluid of the hydrocele. Again, the abdominal wall. Look at 1 and 2. The needle is going the midline and needle is going on the lateral aspect. Layers. IVC obstruction, thoracoepic gastric vein dilatation. It is different from caput medusa. Peritoneum, epiploic foramen. Look at it. Look at the greater and the lesser sac. Hepatic segments, right and left lobes. How to differentiate? Which is medial, which is lateral. Segment 1, 2, 3, 4, 5, 6, 7, 8. The visceral surfaces, you can look at the relation of kidney, adrenal, colon, stomach, duodenum, relations like this. And I told you the H shape, IVC fossa, ligamentum venosum, ligamentum teres, porta hepatis, caudate lobe above, quadrate lobe below. All the vertebral levels being shown over here. Important. D1, D2, D3, L1, L2, L3. D1 is duodenum 1, 2, 3, L1, L2, L3, and duodenum 4 is again L2 because it arises. All the relations around the pancreas, the major vascular relations around the pancreas. Interpersonal relations, we call them in viscera. Look at the pancreas and the kidney, the duodenum and the kidney. Duodenum and right kidney, pancreas and left kidney. Look at their relations. The ureter constrictions, 1, 2, 3. 1 is pelvic ureter junction, 2 is when it crosses in front of the common iliac artery, and 3 is when it enters the bladder. Important. Pelvic diaphragm and liver trani. Pelvic diaphragm is all the 3 coccygeus, pubo, ilio, ischio, and liver trani is only pubo and iliococcygeus. Internal iliac artery. Very important, supplies pelvis and perineum, plus also goes to the gluteal region, and obturator artery that supplies the medial part of the thigh. Anti-flexion, anti-version, just came to my mind that this is, you need to revise it, and all these different permutations and combinations of the anti-flexions and the flexions and the versions. Then we go to the upper limb, the main three nerves, then the carpals, identify the carpals and the radius and ulna. In anastomosis around the scapula and the elbow, the terminal branches of the brachial plexus. And finally the foramen sign positive plus the quadrangular and the other spaces. These are the spaces. This is foramen sign. It is testing which nerve? Remember, it is testing the integrity of the ulnar nerve, because it is testing the adductor pollicis. Finally the spaces, three spaces around the scapula. The quadrangular space, the triangular space. Someone asks you what passes through the quadrangular space. You have to say it is the structures around the surgical neck, that is the axillary nerve. What passes through the lower triangular space, it is the structures that pass into the radial groove. This image, if you see, tell me it is the anterior view or the posterior view. This you should catch. These things are the first things that you need to catch in anatomy. This is the thing that you are seeing from the posterior aspect. The reason why? First of all, you are seeing the spine of scapula. Second thing, you are seeing the triceps. As you are seeing the spine of scapula, you are not seeing the coracoid process. You are not seeing the clavicle. They are all lying opposite. So you are looking at the posterior view of the right scapular region. And these are the structures, the mainly spaces around it. Right? So these are a few things, guys, and don't forget that today we have around a couple of hours left. If you are planning to buy subscription, you are getting 20% discount. 20% is not a small number. I hope you understand. 5-10% you get most of the time, but it is just a double of it. So make use of it. And then these are the batches. The 9-month batch and the 6-month batch for the repeaters who have done at least given the exams once or twice. And finally, this iconic price is also going to increase. You can use the codes. This was a small session from my side, guys. I know that we can't use a pen, but I tried my level best for you to recall the held topics. I guess we did around not less than 25, 30, around 30 topics is what I get a vague idea of it. Right. That's all, guys. Any issues, anything you didn't understood, you can write in the comment box, call the Telegram groups or the Unacademy app. And they also feature known as I took 2 tests today, DBB direct live test, something like that, in the community app, in the community feature of the Unacademy app. So update your Unacademy app. In the community feature, you get the tests, so you can attempt them. You can look at the leaderboard. Any queries you can ask also. Right. That's all from my side, guys. Bye bye and good night. And that's all. Thank you. Bye bye.